to review various suturing techniques that can be used for most often with blunt trauma to the eye, which is 12 times more common in males than females. It is usually unilateral. Studies from India have shown that the injuries occur in patients of the lower socioeconomic status, and 92% occur from rural areas. The most common agents that are involved are wooden sticks, firecrackers, and bows and arrows. Key was the first to address iris reconstruction in 1917. He sutured the iris to the adjacent sclera in order to manage an iridodialysis. Emmerich put forward the concept of iris-to-iris repair in 1957. One of the more common iris-to-iris repair techniques is the suture sliding knot. The suture is passed through the corneal incision, through the two ends of the iris, and out through the cornea. A Sinskey hook is then used to bring a loop of suture out through the main incision adjacent to one end of the suture. That end of the suture is then looped around the loop and tightened, and then this process is repeated. This individual has a large defect in the iris, which would be amenable to the suture sliding knot technique. Having made our main corneal incision, we take our suture and pass the needle through the incision, through the iris, and out through the cornea. This is a PC9 needle. We then will take our Sinskey hook and bring out a loop of the suture through the main incision adjacent to our one end. And then we will loop our suture through that loop, and we will repeat the process. We cut the suture. And then we repeat the whole process one more time to get a better closure of the defect. And as a final point, we pull the iris so as to break any anterior synechia, and here we have the end result. Comparison of the pre-op to the post-op demonstrates that we've achieved a nice central pupil falling repair of the defect. The mechanical suture technique involves passing the suture through the main incision, through the iris, and out through the cornea. A separate incision is then made above the point of anastomosis, and the two suture ends are brought out through this incision. The suture is tied and trimmed outside the eye, and then the whole complex is put back into the anterior chamber. Iris cerclage involves multiple bites of the iris. The needle is passed through the iris from anterior to posterior and then rotated anteriorly, and another bite is taken. Typically, 4 or 5 bites are taken with each pass of the needle. This next case involves a 15-year-old male who was struck by a stone that was thrown by the blades of a lawnmower. This is what the eye looked like. You can see that there's an area of fibrosis, posterior synechia, traumatic mydriasis with an atonic pupil, and possible inferior zonular dialysis. My position for this case was at the head of the patient. My surgical plan was to use iris cerclage along the inferior aspect of the iris trauma and to use a mechanical suture along the superior aspect. We'll skip through the initial part of the surgery, which involves removing the cataract. Having placed our lens in the bag, our next step then is to mobilize the iris. We break any posterior synechii, and more importantly, reach in with our 23 gauge forceps and try and break the anterior synechii that have been formed between the iris and the angle. This is repeated until we feel that we have mobilized adequate amount of iris. An incision is then made inferiorly, and we will pass our suture to do the iris cerclage through this. So take an initial bite, anterior to posterior, then rotate our needle anterior to the iris and repeat. When we take 4 or 5 bites across, having succeeded in doing that, we will then pass our needle out through the cornea and we'll reach in and externalize both ends of the suture through our main incision. And by tying this partial purse string, we get a substantial amount of mobilization of the iris so as to create the inferior aspect of our pupil. We then cut the suture, and at this point, we will use the mechanical technique to close the superior aspect of the pupil. So again, passing the needle through the iris, out through the cornea, we've created our incision, and we bring the two ends out through that incision, and we will tie this suture outside the eye. And having cut the suture, we see that we have a nice functional pupil. The sewing machine technique is effective for a large area of iridodialysis. It involves passing the needle through the base of the iris and out through the eye. A suture is then placed in the needle, and the needle draws the suture back into the eye. The needle is then used to go through another area of the base of the iris and out through the sclera so as to guide the suture out through this pass. A loop of suture is then held on as the needle is brought back into the eye and more bites are taken. In this way, it mimics the action of a sewing machine. Another technique which is well known is the mattress suture technique, and this requires very little explanation. This unfortunate individual has had an explosive choroidal hemorrhage with extreme iridodialysis and iris trauma. The surgical plan was to use the sewing machine technique for the large area of iridodialysis, and then the mattress technique for the smaller area illustrated. So our first step is to take our suture and to thread it into our needle. This is a straight suture in a 10-0 nylon. And we then take our suture and pass the needle through the base of the iris and out through a scleral groove. We grab a loop of the suture and leave it externalized, and then we create a number of subsequent passes through the root and through the scleral groove. Having made these 3 passes, we will then cut the loops and tie the iris in the individual places so as to get an effective inferior pupil margin. Now, the mattress technique is used to attach a small piece of small segment of iris, which is detached here temporally. So we take the 2 passes, pass them out through the groove, and tie the iris. As you can see, we can have a fairly effective pupil, but it's drawn up. So we'll take our retractor and just remove a small portion so as to get our visual access. And at the end of the case, we have a fairly nice pupil. And if we look at the patient, it's a very good cosmetic effect. The final things that we should consider are iris prostheses, and there are a number of them that are available. This individual has ICE syndrome, and so surgical repair is not possible due to the fragile nature of the tissues. The corneal wound was enlarged, and an iris prosthesis was placed into the sulcus. The corneal wound was then sutured, and then the small tag of iris bisecting the pupil was cut, thus creating an effective pupil. I hope this review of various suturing techniques for iris defects has been of interest to you, and I'd like to thank you for your kind attention to my talk.
Thank you, Dr. Beiko. That was a very nice presentation. Would you like to add on something, or would we take questions?
You can go ahead and take some questions.
Any questions, madam? No questions. See, we have these sutures, steno and nino proline with straight needles. We don't have those with the bent needles. It is a little difficult for us to pass for that encerclage as you showed. That is so easy and elegant it looked, but with the straight needle, it tends to be, we have to hold the iris with the second hand and then bring it up and then take it. But this was so easy. It was so easy looking. So do you suggest bending the straight needle into a curved fashion and then doing it, or?
I think if you don't have access to the curved needle, then that's probably the best alternative, is to try and bend it as much as possible, make it as curvilinear as possible, as opposed to just one bend. Take a number of small bends and try and make it circular as much as you can. And you're right. I mean, it's much easier to direct that needle through the iris than it is a straight needle.
And to the iris root, when we are taking bites through especially the mattress suture or the sewing machine technique, it tends to sometimes bleed from the root where you're taking the needles, especially from inside or even from outside when you're passing that large needle. Do you use a 27 needle, or what size do you use? For the tenoproline, what size suits your tenoproline needle?
I use the short 27.5 needle. It's blue here, and that seems to work quite well. And I think whenever you're doing any of these repairs, you have to be prepared to have some bleeding, and so be prepared to, if the bleeding starts, to put in viscoelastic and BSS and to make the globe as tense as possible and wait for that bleeding to stop and then continue on. So have to be prepared to manage the bleeding, to do a bit of a vitrectomy to remove any bleeding that's there, and then continue on.
So would you suggest an AC maintainer or an infusion port into the vitreous just for maintaining the eyeball globe taut?
Yeah, I think an AC maintainer works quite well for most anterior segment surgeons. They're used to using it. And if you're comfortable putting in a posterior infusion, then that's probably ideal. But I think most anterior segment surgeons are more comfortable doing an AC maintainer. So yes, I agree with you.
And the iris, which is sometimes the dialyzed margins of the iris, they tend to shrink and fibrose. And you have this after they come after many months or few years. And you find that the strip which has been dialyzed to be very short. And so when you're replacing it back onto the iris root, we get a really distorted kind of pupil, which is very grossly updrawn. So how do you decide whether to do a pupilloplasty after doing a dialysis repair? And do you do it in same sitting, or is it Is it on a staged manner? Or?
I try and do most of my repairs at the primary surgery. So, I think you have to be prepared to deal with those contracted pieces of iris. But I think you should also be aware that sometimes, if you manipulate them, you can actually extend and break the fibrosis and get a fairly good piece of iris. So I think in my videos, you can see that there are some cases where the iris is up against the cornea, and when I pulled on it, you can actually get quite a bit of mobilization. So it can be very deceptive as to how much iris is available to you. So I think you should be optimistic and think that you'll be able to get more iris, but if you're not, be prepared to use another technique to get a closure of the defect. And I think, as you saw, I'm willing to sacrifice some of the iris superiorly, because that's going to be covered over by the lid in order to create an inferior margin. So I'll try and create a nice pupil inferiorly and be willing to sacrifice the upper part.
Okay, so what I get from you is that when you have a strip of hydrodialysis, it is good to hold on both sides and try to stretch and see how
Right.
much of iris is available, and then take an adequate bite from the root and get it attached, and then stretch further and see how much of pupil. And what is your opinion on constricting the pupil at the end and seeing how the pupil is going to look like when it is not dilated, and then decide on the table to do whether to do a pupilloplasty or not?
Yeah, no, I think you should be prepared to do some myocall or myostat at the end of the case and see what the pupil looks like. But generally speaking, the pupil is the iris is quite atrophic in these cases, so you're not going to see much of a change. But sometimes you get a surprise. So putting in some myocall or myostat and then reassessing, I think, is a very good approach.
Because I saw you cutting the edges of the iris with the retractor. So if it is a much dilated pupil, and if you cut on that, and then maybe we should constrict the iris and then see the location of an undilated pupil, and then try to create a pupillary margin which will be more central to the optic or something like that.
Well, in the case that you saw, that was over a year after his choroidal expulsion, and that iris was very atrophic, and I was trying to create as much of a pupil as I could with the remnants that I had. I mean, the ideal situation in that one would have been to use an iris prosthesis, but the patient wasn't able to afford it. And in our country, I mean, that's over $5,000. So we tried to do the best we could with the remnants of iris that he had.
Yeah, we just heard from Australia that it is a 2,000 Australian dollars, and the custom made one is a $8,000, a custom colored match one. Yeah, so that has to be actually paid by the patient. I don't think it will be reimbursed by insurance. No,
it's not. No,
it's not. So that is one thing. And many times the edges of, sometimes when you're doing a pupilloplasty, the edges sometimes are thin. I don't know, you might be seeing in Canada non-pigmented iris and also pigmented, because there are a lot of Asian migration which has happened to Canada, and I would think that you will see a lot of Asians coming for surgery. So brown iris you might be dealing with also, many. So do you think that this fibrosis which happens to the iris is more in this thin blue iris, or is it there? And we also see that some of the edges are fibrous, and take a bite through that and just cut through. It's just when you tighten the knot, it just cuts through.
Yeah, no, I think, I mean, I haven't made the observation that whether blue or dark iris has more of a problem that way, but I think you have to be prepared for that when it pulls through. And as you saw in one of the cases, I actually used an implant in order to deal with it. There was a patient with ice syndrome, because the iris in those cases is very, very fragile. You try and oppose it to, and the suture just pulls right through. So if you have that situation, then you may have to defer and come back and put in one of those occlusion iris prostheses that are available from Mosher. At least in our country, they're mainly available from Mosher.
Dr. Viral Shah, do you have anything to ask, please? And Dr. Inder, if you have questions to ask, please.
While
Yes,
Sir,
doctor.
in how many cases there is a chance of cut through of the sutures later on in the post-operative period?
Your question was whether whether the suture will let go in the post-operative
Yeah.
period?
Yeah.
I think the time that you have to be most careful after you've placed your sutures is when you're removing the viscoelastic. You have to remove that very, very gently, because if you go in with your irrigation and aspiration and you have a great burst and the whole diaphragm pushes back, you can lose all of your sutures. And I've seen that happen with one of my colleagues. He did a beautiful, cerclage, went in to get the viscoelastic and basically broke all of the sutures. So I think, and that's when you have to be careful. But once you've left the eye, it's very unusual for the sutures to break through. So it tends to occur at the time of surgery.
Right, sir. Thank you.
And have you seen, we have seen 9-0, 10-0 prolines break when we do scleral fixation. But in iris, I have not seen these disintegrate and break. They stay on. Have you, what do you say?
I agree with you. I haven't seen any break. I mean, our numbers aren't huge in these patients. It's not like we're following hundreds of them, but I haven't seen them break through over time. And so I think, you're quite safe using the 9-0 or the 10-0.
Yeah, disintegration is very, very less likely, but I was just apprehensive that any kind of the cut through or say not loosening and all that.
So what is your, as he's asking about the knots, what is your standard number of knots? Because nowadays I have shifted mostly to this single pass 4th row. So that seems to hold and you don't need to bring it back and make multiple throws. So I'm doing 4 throws and staying good. But still I see that you are doing the seepsers and you're repeating. What is your take on that, please?
I think I've switched over to the 4th row pupiloplasty as well. But I mean, the number of cases that I have of these pupil repairs extend over years. And so what you're seeing is the initial cases in which I was doing the other technique. But right now, I think, most of the cases are 4th row pupiloplasties, as MR has shown us. So,
okay, I think we are joined by Dr. Ashinov. He's already here. And it will be nice, both of you meeting in the same webinar. And so hi to both of you. And you do you have to add on something onto this topic, sir, before we go to yours?
Well, I must confess, I missed the first part. I was sleeping. George was up before me, although we live very close together. Hi, George.
good morning.
That was a very good talk.
Thank you.
Those are always problematic cases. And I basically concur with everything you've all said. They tear through sometimes, you have to be very careful. And I think the point about taking out the OVD carefully is a very good point. There are many cases in which often you have the highest risk taking out your OVD with high stress and force. So be careful of these cases. Good work.
Yeah, maybe I think we should, we have the option of a Simcoe, which goes through a slightly larger incision. So it may not fill up the anterior chamber too much and make it too deep. Maybe it will retain the chamber shallower. So or you have an irrigation kept very low so that it doesn't deepen out the chamber or something like that.
Well, I just use a simple cannula and I wash carefully. And if you take your time, it comes out. It takes a little bit longer, but it works perfectly well. And it's very careful. You don't want to shake up delicate things you've just put together.
Yeah, exactly. I think we should keep the irrigation low and then aspirate gently and keep the chamber just formed so that it doesn't deepen out too much or shallow too much.
But by the time I went into training, all the Simcoe needles were taken off the cataract trays and put into storage.
I think
Yeah.
we can buy new ones and add on to the sun. I still buy Simcoes. So when they go bad, many people don't use it, and so we don't get it. So every conference I go, I buy a few Simcoes and keep it standby. Because I teach most of my residents to use Simcoe. because sometime or other they will somehow face up a situation where they'll need to use a Simcoe. Especially here, the manual small incision cataract surgery is also very popular, and so they are all used to using a Simcoe. And there are good Simcoes which deliver good irrigation and a small aspirating port, but they come in very different sizes and they look very odd in different situations. But then when they are used to one kind of good Simcoe, I tell them to stick on to that and buy more and keep in stock. It will help in situations like this.
Yeah, totally agree with you, Dr. Meenu here. Dr. Meenu, can I ask a question?
Yeah, please carry on, sir.
What is the incidence of secondary glaucomas in this case where you have done iridodialysis repair? Because there is maybe some amount of bunching of peripheral iris in that quadrant. Maybe it depends on the size of iridodialysis repair. So I would just like your comments and Dr. George Beiko's comment on this.
I think we'll take it from Dr. Beiko first.
Yeah.
Well, all of these cases in which you've had trauma causing, any kind of damage to the anterior segment, the patients are prone to having glaucoma in the long term. So you follow these patients quite closely and manage it. I haven't been impressed in any way that there's an increased incidence of glaucoma after the repair. I think these patients come to you with damage to the angle already, and you're managing the glaucoma prior to going in and doing the surgery. So, if they have glaucoma and you need to address that at the time of your repair, I think you have to be prepared to do a filtering procedure in those patients. But I haven't been impressed that that's become more of a problem after the repair.
Yeah, I mean, that is my experience also. I have not seen a patient develop glaucoma just because of an iridodialysis repair. Even if you repair 180 degrees, you will have, if the rest of the trabecular meshwork is fine, I think they'll go ahead without having a problem with glaucoma. So thank you very much, Dr. Beiko, as we are closing the session at 4:30 time now. Thank you very much for joining. I know the inconvenience of getting up so early and being ready, and you had the backup presentation with you. And because we had the AV problem, you could help us through. You thought your connection will have an AV problem, but anyway, our connection was well maintained and it was nicely seen. Thank you very much, sir.
Thank you.
And thank you very much, Dr. Viral Shah, Dr. Inder.
Thank you so much, Kerala Society of Health, for the opportunity, sir. Thank you, Dr. Meenu, sir.
Yeah.
Fantastic presentation, Dr. George.